passive. All these movements can be passive or active assistive, meaning that if it's passive, you're doing all the work. If it's active assistive, the patient moves with you, okay? All right, so the patient is for shoulder flexion. Here, the key to, lie down, thank you. So the key to the shoulder flexion one is we're also looking for, obviously, your body mechanics so you don't hurt yourself. And I love doing the footwork for this one. So if I'm doing shoulder flexion, you want to get the feet. You want to watch the feet. I guess I should do it on this side so you can watch the feet. The feet, I'm sorry, I'll do it this one. The feet, I'm just doing this side, and I want to go into shoulder flexion. I hold, if this is the patient's right hand, I'm holding the wrist with the left hand. I am not holding their fingers. I am not doing anything to hurt them. I'm holding them in a position where they're comfortable. I like doing something like this, because picture the patient's in a coma or paralyzed. You don't want to hurt them. So holding the fingers is not safe. You don't want to grab the wrist like this. That's not good. You want to hold the position nice and soft, okay? If anything hurts, let me know to show you that it's not painful. And the other hand is I'm protecting joints, right? I'm not just letting joints dangle. I'm protecting joints. So I'm holding, if it's his right hand, I'm facing his feet. Left hand holding the wrist, right hand on the elbow, and watch. You see that? Pretty cool, right? No. So you could do this, but you don't have to do it. I just like doing it this way. And you see that the patient's shoulder is an internal external rotation. That's internal rotation. That's external. This would be neutral. External, thumb. When you're in external rotation, that's external rotation. Right? Especially with abduction for sure. But you don't want to have full internal rotation. So you can have neutral, but you want to think about it. If you're full external rotation, I'm doing this, that's painful. Right? Another tidbit for this that I enjoy saying is if you want to get the full natural range of motion, you want to make sure that his scapula is free. If his scapula is really put down or it's not mobile, then you're just getting glenohumeral movement. If you want to get full scapular movement, you want to make sure the scapula is free to move. And on this table, his scapula is off the table, that's fine. Just little tidbits. So you see, that is flexion. And I go till I feel, right here, I feel resistance. Why don't you have full range in your shoulder? Probably 1,000 reasons. Check this out, relax. Look at that. He's lacking range in that. So the minute you're a good person to work on. I feel the resistance, I am not pushing. That's next lecture. We're not stretching, we are just going for the range. Got it? That's shoulder flexion. Wait, I'm gonna go to share, wait, present. Who thinks they could control this? Are you ready for this? You advance it when I say.
Great responsibility.
That's a big responsibility. So that's shoulder flexion. Extension, this is not extension, right? We need the patient to have their limb off of the table, correct? So there's two ways to do it. One way is if I have the patient come to the side of the table, and I could just, again, I am protecting, I'm sorry, I can do it on that side. Next time I promise I will. I'm protecting the elbow and the wrist, and I'm bending the elbow and going till I feel resistance, right? I'm not pushing it more. I'm letting gravity pull it down till I feel resistance, but again, I'm protecting limbs. The other option is to lie side-lying if the patient is mobile, and again, I am going back to protect limbs till I feel resistance. That's two ways to do shoulder extension. Got it?
We don't ever do it in prone, like this?
You can do it in prone. This is much more control and comfort. In prone, you're pulling back. It's not wrong. I don't know if it's the most comfortable. But also if the patient is like incapacitated.
Right, yeah.
Or if the patient had surgery here, you want to start laying on it. Those are two good ones, but every situation is different. I'll buy that. Abduction. The patient is lying. Thank you. You're good, Ryan. Abduction. So again, the shoulder should be in deep internal rotation, correct? No, external rotation. For example, if I have the patient in full internal rotation and I go into abduction, I'm feeling resistance, right? I go into external rotation, wow. So the patient must be in external rotation. The thumb must be up. And again, I'm protecting and I'm going as far as he lets me go. And that's pretty good. He is full. Got it? That is internal, that is abduction. The key is having the thumb up. You see the notes, see the work that I do for you guys? We did that one, external rotation, good. Horizontal AB and AD. Oh, first internal and external rotation. So that's abduction. For shoulder internal and external rotation, I want to make sure to be in what position? 90-90. 90 of abduction, 90 of elbow. See that? And then I am protecting here. If the shoulder is on the table, I really don't want the patient's shoulder to be rubbing on the table. I don't like that. So I like to have the shoulder off the table, but I'm still am protecting the limb, and I am letting them go into internal rotation until I feel resistance. Again, I'm not grabbing the fingers, I'm holding the wrist, but in a safe way. It's not gonna hurt the patient. I'm letting him go into external rotation. That's a healthy external rotation to make up for your lack of flexion. Okay, good. Horizontal AB. If I'm doing this side, again, protecting, you get the theme, right? I'm going across, again, protecting until I feel the end range. And AD, this is fine. I don't need to go past to have him go all the way down. Horizontal AB and AD. All right, scapula. The patient is sidelined. Good. Okay, so obviously you put a pillow, but anybody have an exposed scapula? Oh, you're filming.
Oh, no, I can ask someone to do
All right.
Yeah.
Good. So let's lie side lying. Can we get a pillow for comfort? Because patient comfort is paramount for me. Put your head here. Side lying. All right. Okay, there's the patient's scapula. Here comes the pillow. Fresh from the whatever you call it.
Pillow pile.
Yeah. Okay. I am feeling on the patient for the superior border, inferior border. I'm cupping it. Okay. There's a bunch of different ways to do it. You could do it this way. That's fine. You could do it anyway, as long as you're getting in there. You see the scapula? You could feel it. And now I have full control of the scapula. I could do elevation, depression. I could even put his elbow into me if he could handle it. And I am controlling elevation, depression. I am controlling protraction and retraction. I am controlling anterior and posterior tipping, which we'll get into in the shoulder lecture. And I'll get into upward rotation and downward rotation. Everybody see that? Do you feel all the movements? I have total control of the scapula. I can do all kinds of movements. If you're short like me, having a step's a good idea. Or you could have the patient a little closer to me. But with this, I could do all motions. It's pretty cool to control the scapula. We know the muscles that do all those movements, right? Mm-hmm. All right, we'll talk about all the muscles that do all those movements. Good, that's scapula. What's next? Elbow, this is the hardest one. Elbow flexion and extension. Are you ready, Kevin? Flexion and extension. But it's important to do it in pronation and in supination. All right, what does the bicep brachii do?
Supination.
It supinates, right? So it's good to do it in supination. It's also good to do it in pronation. So I like doing it in both. But again, I'm protecting the elbow so it's not rubbing. I'm protecting his wrist, keeping it in pronation and supination. Did I get everything? Pronation and supination, I got all that. Okay, how would we fully elongate the biceps brachii? Or the biceps? If I want to fully test or get full range, what do I need to do? What motions do I need to do to ensure that I get full bicep movement or get every part of the muscle working when I work it? what does the bicep do? So typically, just do the opposite of what the bicep does. The bicep does what? Shoulder flexion, right? So we're not going to be up here.
Yeah.
What else does the bicep do?
Elbow.
Elbow flexion, so we're going to be in extension. What else does the bicep do? Supination, so we're going to be in pronation. And that's correct, you're doing a motion. When you stretch, that's a great way to stretch because you're doing extension, extension, and pronation. So that's a way to, and I feel it. I feel the bicep. So that's a good way to really test the range on all parts of the joint. Make sense? How would I do that with the triceps?
This kind of thing.
Yes, because the triceps extend, right?
elbow.
Yes, that's right. And they do work on some extension of the shoulder, believe it or not. So if I do full flexion, have a seat, face there. If I do full flexion, and it's okay to do this, by the way, to get in there. Right, I feel the resistance, I stop. I'm getting shoulder flexion, and I'm getting elbow flexion. Good. And you're tight, sir. I cannot do that picture on you. But again, we're not doing stretching, we're just doing for the range. Questions thus far? Yeah, no questions, we're just doing it. Okay, so that is good. If you understand the muscle, like you learned in kinese, then moving the muscle is easy. 99% of the time, if you do the opposite of what the muscle does, not knowing the origin and insertion. Can I tell you the origin and the insertion of the triceps?
Yes.
Somewhere in the, right there, and somewhere over there. Well, I know what it does, and that allows me to work it. Okay, next. Pronation and supination. Go lie down again. So, when I'm doing pronation and supination, I do not want to hurt any limbs, so again, I'm protecting here, and I'm turning. I'm not doing it here. Okay? Simple. When I feel resistance, I stop. Another technique is the sandwich technique. Mr. Mitchell loves the sandwich technique. As long as the elbow is off the table, you're not hurting the elbow, you could do this. And the sandwich technique is a safe technique because you are not, you're sandwiching you're not hurting any fingers, you're not hurting wrist, you're protecting the wrist, and you're doing the sandwich technique. Either one is fine with me. But as long as I see you're protecting, you're not letting limbs run limp, that's no good. Okay? That is that one. All right, when it comes to, if you want to do, for the fingers, we always stabilize proximal and we move distal, not the opposite. So I don't hold distal and move proximal, no good. I stabilize proximal and I move distal. So if I want to get wrist motion, I stabilize proximal to the carpal bones and I slowly go into range. Right? Same thing with ulnar and radial deviation. Right? I stabilize proximal and I move distal. Same thing for the fingers. If I want to move the MCP joint, or if I want to move the MCP joint, then I put my finger my hands by the carpal and I move the MCP joints. If I want to move the pips, which stand for
Proximal.
interphalangeals, then I stabilize the MCP joint. If I want to move the dips, the distal interphalangeals, then I stabilize the proximal interphalangeals and I move them. Make sense? What's cool about the wrist is that they play a role with the fingers. So if I want to try to stretch the wrist extensors over two joints, then what do I do to the MCP joints? Flex them or extend them. Again, I want to do a full elongation of the extensors. What'd you say, Alan? You flex them, right? If I do flexion of the MCP joints and I do flexion of the wrist, that elongates all the wrist extensors. If I would do a stretch, you would feel it more this way than if I let the fingers relax. The same thing holds true when I'm elongating the flexors, right? If I have the MCPs extended, then I am getting more of an elongation or feeling the full than if I just let it relax. You feel the difference than if I go like this? Because there are muscles that cross both joints. You understand that? Mm-hmm. So if you just want to get elongation or see range in the wrist, then you leave the fingers alone. If you want to get full elongation or you want to see the full available range of the muscles over 2 joints, then when it comes to extension, we extend the fingers, and when it comes to flexion, we flex the fingers. Good? And if you want to work on the dorsal or volar surface, you could just cup and go this way and that way to get to see the full range. Next, we got all that, we got all that. We did the fingers, that's the fingers over 2 joints, get it? So that's the extensors over 2 joints and the flexors over 2 joints. Next, all right, for the lower extremity, hip flexion, knee flexion. So the thing about the lower extremities, you might be a small person and you're dealing with a big person. Or you might be a big person and you're dealing with a bigger person. So it's important to be able to not work, get burnt out over 2 days of work. Because you might get these 365-pound football players. So that's why it's important to know how to range a person. So if the person is small, no big deal. Boom, easy. If the person's big, you have to know how to move them. So having one hand by the knee joint, protecting, one hand by the ankle joint, and you start moving, and once you get past where it's heavy, then, sorry, I'll do it on this side. So I'm getting the range, now I'm starting to get more range and the patient's really heavy. If I bring them close to me and I protect, I could do a lot more work this way than doing it like this, which is heavy. This way I have much more control and it's much easier. You see the difference? So realize that's why it's good to work on multiple people, not just the smallest person or the biggest person. Muscle weighs a lot. If you want to know what muscle feels like, you come work with me, all right? So it's good to work on various types of people. Okay, what's next? So that is the knee flexion and elongating the hamstrings times 2. Does that make sense? Right? The hamstrings, we are getting full range because we are stretching at the knee joint and stretching at the hip joint. But we're not, once we feel the resistance, we stop. Okay, also I like to put us a little bit of pressure, not on the kneecap, that's painful, above the kneecap, because this way, as the patient, his range is limited, he'll start bending his knee. But I just got to give a little push and just hold until I feel the resistance. All right, next. AB and adduction. Again, very simple, you just don't want to hurt any limbs. The thing you want to realize that if the patient's contralateral limb is really in, then I'm not going to get a true adduction. So I want to make sure the patient's contralateral limb is abducted so that I obviously will be able to get abduction, but I also could get adduction. And my body mechanics are good. I'm protecting the limbs. I go until, impressive. I go until I feel resistance, okay? Internal and external rotation. Come slide a tiny bit more towards me. I have 90 degrees of hip flexion, 90 degrees of knee flexion. If it's a big limb, I protect it. I hold it. It's much easier than doing it this way, right? This is much easier. And I just use my body to turn into internal and external rotation. The gentleman over there who's not part of this class is an expert at body mechanics because he has done things in his life, which I'm sure he told you that body mechanics are very important. He's taught me this is one of the things he taught me. So I'm doing internal rotation, and he's like, why don't you do this? Watch, he just does this. Just that motion, and look at that. And now, I get external rotation. I feel bad for the guy on the other side of this, right? But it's like little things, but I teach you one way, you're gonna learn your way. My way is I like just doing that extra little piece that Mr. Mitchell showed me. Again, you're not going for the stretch, you're going for feeling the available range. Questions thus far? It's pretty simple. The idea is to practice. Give me my sheets in case I put any tidbits that are on the slides. What's next? We did plantar and dorsiflexion. Okay, so I don't love the picture for plantar and dorsiflexion. I like to have the patient off the side of the table. And when I'm doing dorsiflexion, right, I am not pushing on the toes. That is painful, right? But when I do dorsiflexion, I also want to pull on the calcaneus a little bit. So I'm pulling down on the calcaneus while I'm pushing into dorsiflexion. Okay? Plantar flexion is easy. No one really lacks range in plantar flexion for the most part, I'm going to say. But dorsiflexion you want to maintain, but give a little pull on the calcaneus as you push in the dorsiflexion. Okay? And inversion and eversion, you control, and you do inversion and eversion. Do you guys know what happens if there's plantar flexion with eversion, dorsiflexion with evert? All right, we'll get to it. We'll learn all that cool stuff. So this is your total control of the foot, and you're doing inversion and eversion, like that. Again, protecting the joints that need to be protected. Any questions? No? We're good? Mm-hmm. All right, so that's all the ranges. Let's move on to, where's my PVC pipe, sir? In the storage? Are they here? Oh, they're in storage. All right. We'll do the PVC. I bought some PVC piping. So if you ever want, you know what PVC pipe is? Mm-hmm. And when you take CrossFit, you'll see what it is. They're really expensive, but if you go to like the Home Depot, they're 50 cents. So you could get them at like Rogue Fitness for $20. Or you could, I just went to Home Depot and I'm like, hey, could you cut like a couple of 10 people? Like, it literally was like 50 cents and I got like 4 of them. So we'll do that in a second. Let's go to the pulleys. So you see how all those motions we just did can be passive, where the patient does nothing, or it can be active assisted, where the patient helps you move. I want you to practice both of those, all right? The same thing holds true for the pulleys. The pulleys could be active assistive, or the pulleys could be totally passive. Kevin, I'm glad you're here, because I want to put it up there now. Oh. I'm too short. Okay, so if you look at this, there is a fat part at the end. That goes in the doorway so it doesn't come out, all right? I just sold one of these to a patient for like $15. As you can tell, I splurged on my wardrobe. Okay, so you're gonna put it on top like this. Yes, and I'm gonna close the door. So you make sure the fat part is, you wanna come in this way? Mr. Mitchell's here. Thank you, sir.
Let the man in.
Come on in. Yeah. So yeah, hold it, just watch your hands. And then the door is closed. And now, but I would definitely make sure this door is locked. And this door is locked. Not that I have any stories about it. It's locked. Good. All right, put this away. So, for the pulleys, we can do active or passive. So, to do flexion, let's say I am doing passive range of motion on my left shoulder. My right shoulder is my right arm is doing all the work, bringing my left hand into passive range, right? I also can instruct the patient to actively move as best they can. Let's say they only have half the range. They're allowed to get full range. I'm like, okay, bring your left shoulder as high as you can and keep on pushing, and let's let your right hand do as little help as possible and go for full range, okay? This would be flexion. To do abduction, you simply tell the patient to put their palm out like this. Now it's abduction. They don't have to be like this. It's not comfortable for me. I like doing it this way. And now it's abduction. You see the difference? Good. To do external rotation, I am putting my arm like this, nice and easy, and I'm going, so I start over here, I try to go as much external rotation as possible. This arm, if it's active assistive, is pulling to help. Got it? This could also be down here. Either way is fine. If it's totally passive, the patient's here, this arm is pulling and passively going to external rotation. Right? To do internal rotation, I want to see if you could figure out how to do with the pulley.
Face the opposite way.
Start this way, and all right. There's other ways to do it, but I like that. Fine. You could have the patient in external rotation, and you just pull into internal rotation. Got it? It can be active or active assistive. Are there any more pulley techniques? That's it. Internal, external rotation, flexion and abduction, that's it. The key is to know when to pull or where your positioning is, right? Finally, did I miss anything? Finally is the wand, but before the wand is the pendulum. Anybody ever do pendulums? Yes, you're like this, your arm is just like this, and your body moves, and your arm is just going along for the ride. Why do we do this?
Loosen up the joint.
Right, it loosens up the joint. The patient is not allowed to do any active motion. They could just take off the sling, whatever, if they had surgery or an injury, take off the sling, let it relax, and just move the body around. That's a pendulum. It's a classic passive range of motion technique after surgery. Now for the PVC pipe, we're starting with flexion. What's the first, anybody following along? 'Cause I'm lost in my place.
Must be flexion.
Wand, I could go out of order. We just did Codman or pendulums, right? What's afterwards? Flexion. So flexion, if you're doing active assistive or passive, you could just simply do like this. So this arm goes up as high as it can, right? But this arm is doing the work when this arm can't go up anymore, right? It could be passive also. This arm is just going along for the ride. This arm is lifting, well, this arm, my right arm is totally relaxed, and I'm bringing it up into range. We also could do it, Josh, in supine.
Yeah, like that.
Yes. Josh is lying down, he's starting, yes. Then you're doing elbows straight, starting at 90 degrees, right? If that's where the patient's limit is, so we could go to 90, now we want to get past 90, then active assistive, relax. How can we make this passive for this arm?
Just do more work with this one.
Yeah, or take a cuff weight, put it on here, and like gravity, pull it down. Got it? Good. Now that we're lying down, that was flexion. Let's talk about what's next on the thing. What? What's next on the list?
You're gonna have some steak.
Huh?
This is complete, I don't have the
But there's
other.
a value for the section.
Oh, we did
I
what?
don't have
There's
the
a-
Oh, flexion. Oh, we did flexion or this way. So if we're doing flexion, here's another way. So I'm doing on my left arm. It could be passive. Passive where this arm is doing nothing. My right arm is doing everything. I'm just showing you. Or active assistive. Good. What's next? That was flexion. Extension. So extension, this arm is just hanging out here. My left arm is being treated. My right arm is doing the work. I am just pushing. Right? Got it? So again, it could be passive or active assistive. Next, abduction. Same thing. If I'm treating my left arm is holding on here. My right arm is pushing it into abduction. Again, it could be totally passive. Or it could be active assistive. So the patient goes as high as they can, and the right arm is just helping to get the full range. Next, adduction could be like this. So I'm doing horizontal AD on my left. My right arm is pulling into horizontal AD. This could happen in standing, or it could happen in supine. I'm treating my left arm. Got it? Next,
Internal rotation.
internal rotation. That's a hard one. But the best way, there's two of them, but it's really hard. You see that one? That's a difficult one. My favorite internal rotation is I'm doing internal rotation on my left arm. My left arm hangs out. I grabs onto the PVC pipe. My right arm is pulling up my left arm until the end of the range. This is internal rotation. Got it? Make sense?
Look.
Look, I'm gonna take my hand out. I don't know if that helps you at all.
Well, you're in already.
This is internal. See, this is internal. That's
so
internal.
what does pulling it?
It makes more internal
More
rotation. It increases it. The more I'm pulling up, the more internal rotation. Yes.
Would it be easier to use like a hamstring strap and then just have you pull this way?
It would work with a towel, sure. But I have a PVC pipe in my hand. It totally works with a towel or a strap. I wouldn't use anything that is elastic. Like I wouldn't use a TheraBand, but a towel is totally fine. What's next? External rotation? Okay. So external rotation. There's two ways to do it. One is I'm like this, and I'm going into external rotation. I don't love that one. I love this one. My left arm, my right arm. See external rotation? So you have to kind of get the right angle. So my left arm, I'm pushing into external rotation. And I'm so tight, I feel it like a champ. You see that? Yes?
Yes.
Great. What's next?
Could we do it this way?
You can totally do it that way if you go to CrossFit. Which I do. I mean, I do. You can totally do it that way. In fact, in the stretching lecture, the stretching lab, I have all the PVC stretches. For sure. What's next? The only problem is like teaching you how to do that. Hold it this way, go back, grab. Isn't my way easier? Instead of like having, I mean, you could do it. Hold it in the top, bring it back, grab with, if you could reach it. External rotation, that works too, totally. All right, what's next? Oh, I didn't show two lumbar motions. Somebody lie down, then we're done. Supine. Supine.
So fine.
All right, so we want to get lumbar, we want to see the range in lumbar flexion, right? Who wants to, Joanna, you want to try to get his lumbar flexion? So you could do it this way, right? You want to try that? It's hard, right?
Yeah,
So-
I'm gonna try.
Okay, then I'll show you an easier way. It's hard, you're just a big individual.
Oh, is that
That was
yours?
me.
Joanna?
That was you?
Yeah.
So the key, guys, the key is that Kevin, keep on going, Kevin's butt has to leave the ground. If Kevin's butt does not leave the ground, then you're not getting lumbar, you're getting glutes, let's say. So you have to get his feet off the ground, which is hard.
So, this is enough?
That, yes, or, yeah, you want to get to it, so I like to do it this way. When I'm going to thank somebody, I'm not going to anonymously thank somebody else for this motion. So I'm getting my big shoulder into it. No, you can do it.
Okay.
Put your hand through, rest it on the shoulder, and walk. Look,
Oh!
now walk more, see? And look, his butt, do it again. Butt is off the table, surely.
Let me take the rod
Oh,
on.
it's it. Let's try this. Mike, grab that side. We can do this way also? No, I'm guessing. No, but everyone
No,
should
he
try.
can pull it.
But Joanna,
Kevin
you
can
did
do
it, right? By letting your bigger muscles do the work, and it's so much easier than having to have your small, not your small, anybody's small in comparison to these size. So that is all the things in the packet, I believe. We don't have a lot of time, so from now on.
Rotation?
Oh, in rotation, yes, sorry. Side lying facing me. Side lying facing me. And I am, come a little closer, I am just stabilizing at the knees and just this way. Rotation. Again, not stretching, just letting I'm not pushing him, right? We're not doing that we'll learn another time. But this is just for rotation.
For the right side.
I am stretching, it's a deep question. What muscle does rotation?
Two muscles.
All right, which ones do you like?
Internal of the right side, external of the left side. That does the
What,
right.
multifidus? How about the multifidus muscles?
Oh yeah.
And the rotators. Wait,
That's
there's
right.
other rotators.
Yeah, so the multifidus, the question is, there's a ton of argument if so we're gonna say that if you're doing it this way, we are stretching or elongating as much as possible the left side. There's research that say the right side is ultimately involved, but for sure you feel a stretch where? On this side. So we are testing the full range of his right multifidus muscles, though what actually does the motion, there's a lot of arguments. All right, but now we're just testing looking at the range of his right multifidus. Good. Is that everything? Oh, yes. That's why we have open lab. So now, lie down, Kevin. We have a whole semester of payback. All right, so I want to do extension, correct? So for me to do cervical extension, I am going to lift his, relax, I'm going to relax. I'm going to give him a chin tuck, and that is cervical extension.
Oh.
I'm always going to question it and say
Reflection.
flexion. So why do you keep your mouth shut? But yes, so there's two parts of the cervical spine. When I'm doing this, tucking his chin, I am actually extending his lower cervical spine. I am flexing his upper cervical spine, but very little motion happens there. I'll send a thing to explain it, but this is extension. This is cervical extension. It's normal to be confused.
Yeah, I'm looking at the skeleton chart.
Yes.
Yeah, yeah.
This is extension. Because when I'm pushing back, right? When I am pushing, see, you confuse me. When I am pushing back, I'll send you the picture. It's a great picture that explains everything. But this is upper cervical extension. Cervical extension, and then for rotation, I am lightly turning till I feel resistance, but I'm holding his head at the whole time. And the other way, rotation. Nice and easy. All right? All right? That's everything. I believe in the packet. So we don't have a lot of time left, but for the last 15 minutes practice on somebody, Open Lab will have the rest of it. And like that, you don't have to do this in class. That's the beauty of it. Any questions?
Yeah.
Huh?
Flexion of the neck or just extension?
If you take it, so let's do extension. If you do flexion, you're doing the chin tuck and then you're lifting up flexion.
And then
But extension's cool.
All right.
And side bending we'll get to side bending. Just do these. Questions? It's a lot, but it's not something you never heard of, right? Just taking kines one step further.
And the great thing about this, you can practice it at home. Just get an old school broom
Get a broom.
handle. Practice it. It's
Swifter.
and or a cane if you have it.
Or a cane, or an umbrella,
Yeah, this is great.
or go to Home Depot and
Also, one other thing that Professor Dan did, just like supine again, and Dan,
Yeah.
take him through the double knee lift.
yes, bend both knees.
Stop, right there. Now I want you from here, just slide out. Slide out. Now pantomime the movement from the beginning without touching him. Just come towards me. Come towards me. Now look at his body mechanics. Relax first. Relax. Now just pantomime it without touching him. Go through the movement. No, you step forward on the lift.
No, but then
Okay,
can't-
you're
I
moving. Come on, come on. You're a student.
Here, this is-
You see? Boom, boom. Now do it without touching. This is what body mechanics is about. And this is what we train our athletes at my club. We pantomime the movement about 15 times. No, it's to get the muscle memory. Again, do it a little faster now.
Oh, jeez.
A little teapot.
All right? You gotta get from the intellectual into the body movement. Gotta get the synergy. All the movements that you would do in supine with the patient, you can do it through pantomime without. You get the movement. This is just specificity training,
Yes, and this-
especially with the poles. Great stuff,
Yeah.
people.
And when I do this one, I'm using my shoulder, and you see my body mechanics is this way. I'm
Yeah.
not doing this.
Yeah, yeah, yeah.
Hurt myself.
Because not everybody has the body mechanics that Dr. Dan has. For some of you who don't feel you have the strength, obviously, you do it one leg with someone as long as Kevin. Do it one leg first, but you gotta get, because your low back
Yes, thank you, Kevin.
will
And
go right out.
We're sick of hearing, "Oh, I'm too small for
Yeah.
this." Then you're in the wrong business, because you can't choose your patient. Right.
So master, again, redundant, we say in a sense kinesiology, master your body mechanics. And the great thing about what Dr. Dan is showing you, he's just using different terminology, but it's still kines 101. Range of motion or stretching, whatever that you guys went through. He went through dorsal, plantar flexion, hip, knee flexion, extension. You know that. You just have to keep that kinesiology thought and update the terminology into ortho, but it's the same thing.
And
Right.
now it's treatment. It's no longer
So don't
testing.
throw away your kinesis, people.
No, don't throw these notes. Any questions? Good. We have 15 minutes. Utilize it. Practice all the motions. Any questions on the quiz for, what's the date today? For Thursday. It's on that article, 5 questions. And then the next quiz is next week. All right,